All right, let's jump right into this high-energy explainer where we're tackling one of the absolute toughest battles in medicine. We are talking about fighting cancer, but specifically doing it without letting the brutal side effects take down the patient. When we really get into pharmacology, we're essentially looking at a microscopic war. On one side, we've got these incredibly powerful, life-saving chemotherapeutic agents, and on the other, the massive, severe physiological reactions the body throws back at them. So welcome back to the Confused Neuron Whiteboard. This is where we take these insanely complex medical pathways, grab our imaginary markers, and literally draw them out step by step so they actually stick in your brain. Seriously, no more memorizing endless, dry textbook pages. Today, we're going to visualize the receptors, map out the nerves, and make this pharmacology truly click. We're going to spend a lot of time talking about anti-vomiting drugs in this explainer, but first, I have a really crucial question for you. Think about it. What is actually the most dangerous thing about vomiting? Now, most people immediately assume it's the terrible nausea or, the weight loss. But medically speaking, the true structural danger is severe volume depletion and massive electrolyte disturbance. When you lose that much fluid and stomach acid, you trigger extreme sodium and potassium imbalances. And you know what potassium problems lead to, right? Cardiac arrhythmias. You can literally suffer a major heart issue just because of severe, unchecked vomiting. Okay, so to understand exactly why cancer patients suffer from this kind of severe vomiting in the first place, we have to look at the solution to the cancer itself, chemotherapy. These drugs are specifically designed to cause a lethal cytotoxic event, which is basically just a fancy way of saying cellular death. By targeting actively dividing cells, they literally block the cell cycle. If a cancer cell can't divide, it dies out. Honestly, it's a brilliant strategy, but it has one massive, glaring flaw. And this brilliant little visual mnemonic, our chemo man, perfectly illustrates that exact complication. He shows us that because chemotherapy targets all rapidly dividing cells, and I mean all of them, because it usually doesn't discriminate between a malignant tumor cell and a perfectly healthy normal cell, we get some heavy collateral damage. The toxicity basically hits anywhere in your body that is naturally reproducing cells at a really high rate. Let's actually break that collateral damage down. Starting up at the top, because your hair follicle cells divide so rapidly, the chemotherapy just destroys them, and that leads to alopecia, or hair loss. Moving down the body, your bone marrow is basically a rapid-fire factory for blood cells, so hitting that causes myelosuppression. That means you lose red blood cells, resulting in extreme fatigue and anemia, and you lose white blood cells, which gives you leukopenia and puts you at a massive risk for infection. And finally, your gastrointestinal mucosa, the lining of your gut, is constantly, rapidly replacing itself. When chemo hits that, you get massive GI distress. Which actually brings us to a quick insider secret. If you are ever sitting there, totally lost on a pharmacology exam, you have absolutely no idea what drug the professor is asking about, and you just need to guess a side effect, write down nausea, vomiting, and diarrhea. I'm telling you, you will be right 99% of the time. It's the ultimate default because almost every drug, especially chemo, irritates the GI tract. But we have to remember, in cancer patients, this isn't just a mildly upset stomach. It's a profound, debilitating neurological response. So the absolutely crucial point here is that vomiting is a hardwired physiological reflex arc. It is totally automatic, and we can easily remember the anatomy of this reflex by writing out the acronym SRACER on our mental whiteboard. We always start with a stimulus, like the chemo irritating the gut. That hits a receptor. Then the signal travels right up the afferent nerve to the central nervous system. The center processes it, sends a signal back down the efferent nerve to the effector organs, and boom, you get the final response, a really powerful contraction of the diaphragm and abdominal muscles to forcefully expel the gastric contents. Well, to stop this SRACER reflex in our patients, we absolutely have to target the vomiting center. But where exactly is the vomiting center? It's located deep down in the brainstem, specifically in the medulla oblongata. And right there in the medulla is this fiery little area known as the chemoreceptor trigger zone, or the CTZ. Basically, get in the zone and you vomit. So our primary goal as pharmacologists is to block these signals from ever reaching or activating this trigger zone in the first place. Now imagine me writing this out on the whiteboard in bright neon marker. The primary afferent nerve that carries the nausea signal from your irritated gut all the way up to your brain is the vagus nerve. And the main receptor the vagus nerve uses to actually communicate this distress, that would be the 5-HT3 receptor, which is driven entirely by serotonin. Yeah, it's wild. The exact same serotonin that heavily affects your mood is also what triggers your urge to puke when it hits that specific 3 receptor. Okay, now let's add our blocker to the board.
If serotonin is hitting 5-HT3 to cause the vomiting, it's pretty obvious we need a 5-HT3 antagonist. Enter ondansetron. Ondansetron blocks this receptor right on the vagus nerve itself. And we've got an easy, slightly ridiculous mnemonic to help you remember this one. Ready? Hey kids, let's vomit on 3. 1, 2, puke. Any drug ending in cetron targets serotonin, specifically that 5-HT3 receptor. I'm not exaggerating when I say it is an absolute game changer for chemotherapy patients.
Next up on the board, let's look directly at the chemoreceptor trigger zone in the medulla. Another major receptor sitting right here is the D2 dopamine receptor. We can effectively block this one with a drug called metoclopramide. And imagine I'm drawing a massive red warning sign on our whiteboard right now. We have to be super careful here. Dopamine does a whole lot of other things in the brain, like controlling movement in the nigrostriatal pathway. If you aggressively block dopamine with metoclopramide, you can accidentally cause Parkinson-like extrapyramidal side effects, meaning things like muscle rigidity, tremors, and really slow, stiff movement. Moving right along, what else is sitting right there in the CTZ? Well, there's the neurokinin 1 or NK1 receptor. We can effectively block this pathway with a drug called abrapetant, and the pharmacology pro tip here is just beautifully simple. Just remember that any drug ending in pitant is your dedicated anti-neurokinin weapon. It's actually amazing when you think about it. When you seamlessly combine a pitant with a cetron, you are basically building this formidable, multi-layered brick wall against that entire vomiting reflex.
Now, what happens if the chemo is just incredibly aggressive and the vomiting is totally refractory, meaning it literally just won't stop? Well, in those cases, oncologists will add corticosteroids into the mix. Why? Because they significantly boost the action of all the other antiemetic medications we just talked about. It works like magic, and honestly, it perfectly fits the highly accurate, if slightly cynical, medical adage. When doctors don't know what to do, they give steroids to you. So, when we put all of this together, it builds our complete antiemetic arsenal. This elegantly maps out exactly which life-saving drug blocks which specific receptor to completely stop that SRACER reflex right in its tracks. We've got ondansetron blocking 5-H3 on the vagus nerve. We have metoclopramide and aprepitant blocking D2 and NK1 right at the trigger zone in the medulla. And for some quick bonus points, if the nausea happens to be coming from motion sickness in the inner ear, we can easily use diphenhydramine to block the H1 histamine receptor or scopolamine to block the M1 muscarinic receptor. It is literally a perfect pharmacological map. By mastering these neurological pathways, we can actually save patients from the life-threatening dehydration and cardiac risks of vomiting, which allows them to literally survive their chemotherapy. But it leaves us with a massive, genuinely exciting question for the future of medicine. How can we use this intricate map of receptors and reflex arcs to create future, highly targeted cancer therapies that bypass these trigger zones and healthy dividing cells entirely? Imagine a world where fighting cancer doesn't mean fighting your own body's reflexes. That is the ultimate goal. Keep reviewing your pathways, keep drawing them out on your own whiteboards, and I'll catch you in the next explainer.